McKinsey, sir, 1930.
No, before AIMS, long back, who first initiated or introduced anesthesia record keeping, vital events or the patient's physiological parameters during a surgery?
1930 McKinsey, sir.
No, the chart is, what is the name of the chart?
Hello?
Actually, one surgeon only was responsible for introducing the concept of maintaining an anesthesia record during a patient's undergoing surgery. Can you tell me his name? Which surgeon? He was a neurosurgeon also. Harvey Cushing. No? Harvey Cushing was the person who is actually a neurosurgeon who introduced the concept of making a record. He used to ask one nurse to stay with the patient. In those days, we don't have multi-parameter monitor. You have to manually count the pulse. You have to check the blood pressure with a sigma-manometer cuff. Even when I joined anesthesia as a PG way back in 1975, that was the situation. We used to have our pulse on the hand and tie a BP sigma-manometer cuff and record the blood pressure every 10 or 15 minutes intermittently and note it down in a piece of this. Okay, that is what that used to be the anesthesia record. How many of you still maintain an anesthesia record in your day-to-day activities? Do you have an anesthesia chart which you fill up? And how sincerely you fill up? How you immediately write down the values displayed in the monitor? How many of you fill it up at the end of the surgery after the patient has been shifted? You go to the post-operative ward and make a few markings here and there, especially if it is an arrow marking, downward arrow for systolic BP and upward arrow for diastolic BP as in some charts. You can just put some marks here and there and show as though it has been maintained at a very normal rate all the time. But in fact, it would have been an alpine anesthesia. There would have been a shoot up, then there would have been a decrease. So, to be very frank, many PGs or even assistants or even senior people, when you are asked to manually maintain the record of vital parameters of the patients or the events occurring during a surgery, we very rarely do it very sincerely, and it is of course time consuming and you have to concentrate on the patient's welfare also. So in order to avoid all that, the record keeping was made into electronic system. That is what you mentioned as electronic health record keeping. And because of the improvement in the software that you can program things and then try to feed it, and then automatically when you connect it to the monitor, it automatically takes all the data from there and then stores it. So there is no question of any fudging or falsifying your records. So you get it automatically from that. But at the same time, you have to make sure that it doesn't give a false reading. For example, if you don't tie the BP cuff properly, you may get a false reading. Or if the finger is very cold, the pulse oximeter may give a false reading. Okay, so all that mechanical errors should be rectified before you take this data into the AIMS system. And nowadays, AIMS is considered as one of the good support for you for a medico-legal interference also. Okay, so people in the court of law, if you have a AIMS system and it takes all the detail and patient's parameters have been well maintained during anesthesia, there is no question of negligence. So you are saved because of that also. Previously, even nowadays, when there is a medico-legal question, doctors try to alter the findings and try to correct it. All that correction, if it is found, it is a grave offense. So the AIMS will definitely tell you about the safety of the patient during surgery, and there is nothing wantonly or negligently done. You are quite safe with that. So medical legal implication is also there apart from the other points that you have mentioned. So with these additional points, I would just like to share a PPT on that. So anesthesia information management system has evolved from simple automated intraoperative record keepers in a select few institutions to widely adopted sophisticated hardware and software systems integrated into hospitals' electronic health record system and used to manage the documentation of the entire perioperative experience. So previously we were recording only the pulse rate, BP, saturation, EtCO2, temperature. These values were recorded, but now everything is recorded. For example, if there is a bronchospasm, that will also be noted down. If there is a anaphylaxis, that will also be noted down. So entire perioperative experience or extubation stridor is there, that will also be noted. So apart from the vital parameters of the patient, you can document every single event that is happening during the surgery and anesthesia. And AIMS implementation have resulted in numerous skilling, research, and clinical benefits. Yet the challenges and areas of potential improvement is there still. It is not ultimate now. Now coming to the history of anesthesia documentation, in the 1890s, Dr. Codman and Harvey Cushing pioneered the use of paper documentation of a patient's physiological status during anesthesia. And the paper anesthesia record remained the standard throughout 1900s. Okay, so it started way back in 1890 itself, anesthesia documentation. As computers became increasingly available in 1970s and 80s, there was growing interest among anesthesia providers in the electronic capture, storage, retrieval, and formatting of the perioperative data. So Duke automatic monitoring equipment system developed in the early 1980s was one of the first systems to interface directly with clinical monitors to capture patient physiological data. Subsequent systems evolved in sophistication from simple anesthesia record keepers to comprehensive software and often hardware solutions with functionality across entire perioperative experience, and the term was changed from electronic health record into anesthesia information management systems. So the name originally what was recorded as electronic healthcare record is now called anesthesia information management system because it records the entire experience of perioperative phase. Now, I don't know how many of you had a chance to see this. This is the record we used to maintain in Stanley Hospital as a postgraduate. This is the noseworthy chart. These black dots are all holes. Okay, so these charts are the same identical sides, and it is a two-sided. The front side you will have the patient's name, sex, age, everything, and then the pre-operative findings, the post-operative findings, everything you have to write at the end, and there are examination questions. Beautiful. This chart is very well planned and well created. And on the back side, you will have these columns where you have to, the time is there. You have to mention the starting time, then the events that you do, induction, relaxant, intubation, maintenance, volatile agents, percentage. Then this is the chart to maintain the pulse and BP. So pulse is maintained by a dot and BP maintained marked by a inverted arrow and diastolic BP by an upward arrow. So you have to connect all that. You can time this every 5 minutes or 10 minutes depending upon the duration of the case. If it's a long case, you go for 15 minutes even for one line. And then the total drugs that have been used have to be done here, and any notes that you want to write, you can do that. And these holes will be identical. And supposing you want to make a study of thiopentone being used as a drug of choice, then you puncture this hole, put a steel rod into that and pull it out. All the records that have used thiopentone will come there. or if you use ketamine and again you put the that one iron something like a long rod will be there. You just put it in the hole, so it will go through all that, and you just pull it out. All those ketamine injection records will come out. So this was very much in use in those days. So to prevent this writing on both sides and the difficulty, Nagaswamy devised the anesthesia record card by having holes at the edges which can cut into slots and fills most needs. And until the computers took over, they are cheap, easy to fill and store and classify. And this double-sided record was changed into a single-sided record. So later people have found it difficult to turn it and see it both. See, we become more and more lazy. So single side records were maintained. So you write the same things here, and then the vitals are tabulated here, post-op findings are written here, so that everything is available in a single place. And nowadays, even to do that manually, we are very lazy, so we have gone into computer systems. So AIMS are used currently not only in the preoperative, intraoperative, and postoperative phases of traditional operating room care, but also in other types of patient care such as labor and delivery floor to document obstetric anesthesia, and throughout the hospital to document acute pain services as well as delivery of anesthesia during bedside procedures and intensive care unit. So it has spread its tentacles not only in the operating room but also outside to these various locations. So what is an AIMS? An AIMS is most commonly composed of either a standalone software product or an anesthesia record within the hospital's electronic health record system, coupled with hardware components and physiological device interfaces. So there are three things. One is the hardware, that is the monitor, the keyboard, all these things are called hardware. Then there is an interface to pick up the data, and then it is fed into the computer, and the software processes it and gives you the display. So software is installed on computer workstations at the point of anesthetic care, such as the OR or post-anesthesia care unit, or even in mobile workstations in the intensive care unit. The software on each workstation is called a client, which provides clinician with a user interface that allows access to the anesthesia record as well as central computer server that stores patient data. Standalone anesthesia information management service software on a workstation typically handles the collection of anesthesia data on the workstation and then files periodically to the central server, which is known as the thick client. If an AIMS is component of hospital electronic health record, then typically the software on the workstation is simply a front-end user interface with most of or all the data filed directly to the central server, which is called the thin client. I'll show you pictures how to understand these two. That is, if the data collected is directly filed to the central server, it is called the thick client. Otherwise, it is called simply from the front end user to the central server, it goes, then it is a thin client. The hardware components of AIMS induce a computer workstation and mounting equipment or mobile wheeled tower, and in some cases can include vendor-specific hardware such as special keyboards, barcode scanners, and syringe pumps. So AIMS hardware should comply with hospital infection control guidelines. Because you are bringing these equipments into the OT, they should not contaminate the OT. So they should follow the infection control so that they can be easily disinfected, and it should be ergonomic, durable, water resistant, and usable in multiple environments. Compatible physiological device interfaces, that is, interface is nothing but the thing which picks up the data, are crucial to enable patient physiologic monitors, anesthesia ventilators, and other monitors to communicate and record automatically with the AIMS hardware. So the device data flow from the devices to the client and then to the server, or first the server and then the workstations, depending on the AIM setup. So in some implementations, the physiological device data flows to AIMS hardware and software through a separate medical device integration interface known as a middleware that typically offers additional functionality such as high fidelity data sampling. A successful AIMS implementation requires not only the appropriate hardware and software, but also a minimum investment of time and peopleware, that is, individuals with sufficient expertise within a department to drive the decision making and implementation processes. So the minimum requirement for a basic implementation, there should be one or more physician clinical champions to guide decision making process and inform clinical workflow requirement. Support from biomedical engineering and information technology personnel for the software and hardware interface between devices and hospital electronic systems. Advanced requirements of the state-of-the-art AIMS implementation within an institution. Requirements listed in minimum requirements. Data scientists with expertise in visual and advanced analytical descriptive predictive should analyze the data. And database system administration to handle AIMS data queries. And because it involves a lot of computer involved, all these data are to be analyzed by experts. And so the doctors should get trained with that. Physicians with informatics expertise to spearhead clinical decision support and data analytic efforts. And EHR AIMS programmers for implementing clinical decisions as support tools and project manager. So this requires not a simple clinician, but also people who are trained in handling a software and hardware system. So if you see this is the these are all the three types of architecture: monitoring network, device integration, and using the monitor. So here you have the anesthesia machine, you have the anesthesia monitor. Okay. So this is the AIMS workstation, which is also kept along with these things. So the anesthesia machine itself has got the monitor, and there is a workstation which is also kept inside the room, and it user entered data go to the outside to a personal computer in the local area network, and there are monitors outside also to monitor, and it goes to the IT server room where it is stored in the database. Or it can be a device integrator can be there. So here if you see, this one collects all that and sends directly to the IT server room. Whereas here there is a device integrator which is connecting this to the AIMS workstation and takes it there. And in the IT server room, you have a device interface server as well as a database server. In the third type, you have the AIMS integrator, the integrated device which is attached to the monitor, and then again they are taken here, and this is directly delivered to that. So if it is going directly like this without any other intermittent connection, then it is called the thin client. If it goes through several, it is called a thick client. Of course, that is just for understanding. You need not worry about that. So perioperative documentation with AIMS, what you do is the core function of AIMS remains a the generation of electronic anesthesia record captures in automated fashion from devices and patient monitors and anesthesia machine. So it takes data from all these things, patient monitors and anesthesia machine, because it can tell you what was the percentage of the volatile given, what is the end-tidal concentration of all these things. Everything can be taken from the anesthesia machine, and you can also allow them to manually document a variety of data. Administered medications can be entered. Fluids and blood products given can be entered. Clinical events such as anesthesia, induction, intubation, all these things can be entered. Patient positioning and how the lines were placed, that also can be entered. Required documentation for billing or regulatory guidelines. That is, what was the time anesthesia was started and stopped, because they charge the theater rent for that period. No? Sometimes some hospitals, the surgeons will say, don't put 4 hours, put 3 hours, then 1 hour reduction will be there. So all those things cannot happen. because it will automatically go into the system, and procedure notes also can be given, and other relevant data that are not captured in automatic fashion, like train of 4 counts. So if you are using a nerve stimulator, you can include that also. In addition to facilitating intraoperative documentation, most aims contain pre-operative patient assessment also. What Noseworthy did way back in 1900s, like writing all the pre-operative findings in the front side of the chart. Now this also has got the same provision to enter all the pre-operative assessment and documentation tools that range from simple data entry from free text fields to comprehensive questionnaires with system-based assessment, richly populated drop-down menus, and capability to store and display patient photos, and graphical tools for annotating images of dentition and other patient characteristics. So all the important points about the patient can be recorded. This is why this has become a very important tool for saving you from medico-legal problems. So an AIMS that either has access to or is integrated with hospital EHR system can load relevant patient data such as allergies, medications, procedure information into the preoperative assessment and intraoperative record. Other typical features in preoperative AIMS module should be ability to peruse patient's previous anesthesia records, a review of systems and physical examination, and document an anesthetic assessment and plan. All these things also can be included in that. And many AIMS facilitate postoperative documentation using a computer workstation at the patient's recovery area destination, such as post-anesthesia care unit or intensive care unit. And it's a very good tool for handover of the patient. So during handoff of patient from one clinician to other areas, it is a very useful transition, will be very smooth. And AIMS can also display prompt use of enter the quality of improvement relevant documentation, notify the user of deficiencies, and real-time alerts and text messaging notification can improve the quality of documentation. So if there is any fault, it will immediately give you a indication that something is wrong and you have to look into that. The benefits and obstacles, these are all the lot of things that have been given. They are taken from an article. Improved patient safety and quality care, that is number one. Then improved documentation, precise, accurate capture of intraoperative events, generate high resolution anesthesia records, automated real-time, near real-time notifications of missing or incomplete documentation, enhance legal fortification due to unbiased and precise records, facilitate risk management. So these are all the improvements in the documentation. Improved patient operations management. So billing personnel workflow is easy. Enhance anesthesiology department's administrative role in pre-operative setting. So there are several advantages like this. Improve cost containment and reimbursement, and improve clinical research. So enables researchers to search quickly for rare events or specific. So just you type, just like searching your Google, you can just type something. You want to see how many cases developed allergy after trachronium or a trachurium. You just type it and immediately all the data will come. So you can do easily all the research work. So the advantages are improved patient safety, improved documentation, improved operations management, improved cost containment and reimbursement, and clinical research. So there are 1, 2, 3, 4, 5 advantages of this. But the obstacles for this current usage, because every hospital cannot afford this. So reluctance to abandon paper records. Some people are old timers, will never allow. They will say that whatever electronics is there, that also can make mistakes. So I believe in my own documentation. So paper records are still maintained by somebody, but the cost is very, very high. Unacceptable cost of installation and maintenance. Distraction of anesthesia providers. Every time you may have to sometime use the keyboard and enter all these points. So that may distract the anesthesia providers. And medico-legal concerns and resistance to change in clinical workflow patterns. So these are the obstacles. But AIMS can result in a positive net return of investment in 4 areas. More efficient staff scheduling, resulting in decreased staffing costs, decreased anesthesia medication costs. That is, if you go on this repeatedly noting the record, you can say that one day if you have 5 cases in the list, you can adjust your use of propofol and other things by knowing how much you have to use. So medication costs can be brought down and improve the charge and billing capture, increased hospital reimbursement from improved hospital coding. So these are the advantages. And minimal impact on vigilance and accuracy of practices, recall for variables. Just because AIMS is there and it is recording all that, they have found out that it is the doctors don't become slack. They are vigilant all the time, but they are taken off the burden of recording everything manually. So that is the advantage of that. As for medico-legal concerns, AIMS valuable for risk management, and there were no cases reported so far in which AIMS hindered the defense process. So AIMS is not been blamed for negligence. So AIMS-based clinical decision support. Clinical decision support is a recent advancement in AIMS development, and it can be grouped into either administrative, that is maximizing over efficiency, or impacting care processes, such as improving adherence to clinical protocols and guidelines. And the AIMS-based clinical decision support consists of a wide variety of alerts, reminders, notifications to modify the behavior of anesthesia practitioners that can affect many perioperative processes. That is correcting OR location errors, ameliorating intraoperative hypothermia, restoring alarms after cardiopulmonary bypass, improving beta blocker medication compliance, guiding postoperative nausea, vomiting, and antibiotic prophylaxis. So you name anything, everything is included in that, and I think this is going to be the future of documentation and record keeping. Okay. So secondary uses of AIMS data, implementation of AIMS has facilitated clinical research and collaborative projects across many institutions and anesthesia practices. So for understanding the picture, this is the AIMS component. This is the screen that is there, the keyboard. So you can enter whatever you want by typing on the keyboard. And this is automatically integrated with your anesthesia machine. So this is how usually it is located. And the display will be something like that. So all the parameters are there and you will get a display like this. So you can even monitor, and any real-time alarms are there so that it will immediately give you a signal to find out whether there is anything is going on or not. Okay. Right.